Good morning, everybody. What a great start to the day, right? Congratulations to Dr. Konofko and Dr. Woodworth. Amazing people who are bringing innovative ideas to the clinical patients, so thank you. So I'm Suzanne LeBlanc. I'm the Director of Clinical Relationships at the Focused Ultrasound Foundation. I'm thrilled that many of you are here today, but also recognize and appreciate that for various reasons, some of you are attending virtually. For familiar faces, welcome back. For new faces, welcome to our family. Today's panel sessions will focus on mainly non-oncologic brain indications. However, stay tuned, because this afternoon you will hear a special keynote address from Jeff Martha, the CEO of Medtronic, a discussion on why advocacy is critical to the adoption of focused ultrasound, and finally, an informative and transparent view of the trials and tribulations of startups with Bradley Horowitz, the vice president at Google, and Michael Marquez, founding partner at Murado Ventures. As a reminder, all oral presentations have been pre-recorded and made available for you to watch. We urge you to watch these dynamic presentations, interact with the presenters, and also leave comments on the platforms and on the app in your free time. Again, thank you for attending. Now, to start the sessions. Up next, we have the Tremor panel, and I'd like to introduce Dr. Reese Cosgrove, who's going to moderate, and I want to invite all of the panelists to come up, and they will be introduced soon. And this will be a really engaging and new way of interacting with these experts in the field, and I hope you enjoy it.
Yeah, so my name is Reese Cosgrove. I'm the head of epilepsy and functional neurosurgery at the Brigham in Boston. My pleasure to introduce this star-studded panel. We have Gordon Baltuck from Columbia, Mike Caplet from Cornell, Pedji Gunani from Stanford, a radiologist, Cheyenne Musa from UVA, where a lot of this all started, and Margaret Ferris, a neurologist from Stanford and formerly from University of Maryland. So we have this star-studded cast up here. We're going to focus on a very now well-accepted application of focused ultrasound procedures. Can we have my first slide? So I'm going to just start by recapitulating the state of the art and maybe start to ask some questions about where do we go from here. I have the rudimentary disclosures. I receive clinical research funding from Insight Tech. I'm also a consultant for them. But my true confession is I still really love the stereotactic frame. I sometimes wear it around just in the department to scare people. So I think everybody is familiar with the procedure, the Insight Tech device in which we use it on a regular basis. The beauty is that it's a 2 to 3 hour, it's non-invasive, it's an outpatient procedure. The patient is awake, of course. We target the brain directly while the patient is in the MRI scan. We can do stepwise adjustable lesioning. And at the same time as we're doing the lesioning, we're monitoring it thermally. And then after every lesion, we bring out the patient and test them. So if somebody, can you hit that embedded video? Because I'm pretty sure it's not going to work for me. So this is what it looks like. No, it's at the bottom of that one. If you just put your cursor on. There's a patient who has a very significant lateralized postural tremor. Okay, and now can you hit that one again? And this is after 1 or 2 lesions. I have to move it's like magic, the tremor's gone. It happens immediately, it happens on the table. So where does this fit in movement disorder surgery? Well, at our center, we use it as an alternative to DBS in selected patients. So the elderly patient who is too old for DBS or is at higher risk, those patients who have medical contraindications, There is a whole percentage of people who really don't want implanted hardware for the rest of their lives in their brains, and they clearly have to be willing to accept a unilateral treatment. We've done nearly 300 focused ultrasound thalamotomies to date, and this was our most recent paper looking at our first 160 patients. A classical breakdown. Usually we treat the dominant hand even if they have bilateral tremor. What we found is that we see across the board an 80 to 85% improvement, average 80 to 85% improvement in the contralateral tremor. It's nearly completely abolished in 2/3 of these patients, and that, in our experience, is sustained at least out to 2 years, and we just recently published the 5-year data on the original InsideTech trial, which also demonstrated even at 5 years there's sustained improvement on average of about a 75% improvement of their CRST score. So it works, it's enduring. But it's still surgery on the brain. I call it no-touch brain surgery, but it's surgery on your brain. And therefore, when you operate on the brain, can be complications. And we see side effects in the majority of our patients, at least. The example on the left there, nicely sized lesion, a little too posterior, sensory side effects. Middle lesion, way too big, great tremor control, dysarthria, and imbalance. The right one shows the tail into the capsule. Weakness, dysarthria, imbalance. That's the feared complication. When we looked at all of our side effects across the board, you see there's a predominance of side effects. They tend to all be mild and they tend to be temporary, but not all. And the two that really stand out in our experience is the paresthesias, which are typically minor and you have to ask the patient for them, so it's not a major side effect, and it's certainly a reasonable trade-off, but those should be reduced. The imbalance is the most common one. It's not ataxia in our experience, it's an imbalance, and I think it has to do with lateralized hypotonia and decreased tone. But these are the two that the patients complain about. So our goal is to have a complete and enduring tremor relief without any enduring side effects. How do we do that? Accurate target selection and accurate lesion placement. If I was doing this, and I've done probably 100 of these with a radiofrequency probe, I would target the VIM thalamus, I'd place my electrode tip down to the intercommissural plane, I'd place my first lesion at and just extend a little bit below, and then I'd withdraw 2 millimeters, make a slightly bigger lesion, and draw it a third time, make a slightly bigger, a smaller lesion up top. That's how I would do it if I was doing it open in the conventional way. And it all has to do with location of your targeting and placement of your lesion. So things haven't changed, it's just the tool that has changed. What's the optimal size? Well, that's right on target, but too small. No side effects, tremor comes back. That's on target, but too big. No tremor, but side effects. That's on target and just right. So good tremor control, no enduring side effects. So it's the location and size actually matters. So this has been our experience, and I think experience of many of the panelists here. These are some of the issues that we would like to address in this session. Margaret, what are the barriers to patient selection and referral process? How does it fit in with DBS, the accepted treatment? How do we optimize our targeting and placement of the lesion? What's the perfect size? What's its shape? What shape should it be? How far should it extend? What did we do with low SDRs? I actually think that higher SDRs can be more complicated and more dangerous, but what do we do with the low SDRs that we can't get a lesion to develop, and also what do we do with our failures? I always think we learn more from our failures than success, but what do we do with our failures? And then what is the role of bilateral treatments? So the brains are all over here. I'm just a simple end user. We're going to turn this over, and we've asked each of the panelists to give a short précis of their discussion points, which we've asked them to address. And the slides will come up automatically. So you're welcome to, maybe we'll just go from the panel, I guess. Just speak from where you're sitting.
Let's show the next slide.
Next slide. Can I do it from here?
Okay,
Gordon's first.
You want me to advance the slide? All right. Oh, thank you very much for inviting me to speak this morning. It's just been great, and I really appreciate everyone in the audience who's helped with the work that we've been doing over the years in treating these. Reese asked me to talk about what many of you know as machine learning, but the OGs like myself know as clinical experience. For reasons that are beyond the scope of this talk, we see a lot of patients with low SDR, and I can comment on high SDRs as well, because I agree with Reese that in some respects high SDRs are more dangerous cases. But what happens with these low SDR cases that we get to see that are below 0.4? What are the sort of the challenges that we have in terms of making lesions in these cases? I think there's some basic sort of clinical caveats. This isn't scientific, but when you see cases like these, the question is, how are you going to make a lesion? Let's see, next slide. First of all, who are you going to exclude? There are going to be people who have low SDRs that we're just not going to be able to make a lesion in. And when we look at those, a lot depends sometimes on the size of the head and the patient. Someone with a smaller head, classically who is female, we can get down to 0.25 and be successful and have been successful. A gentleman with a large head, sometimes we've actually been unsuccessful at 0.4, 0.41. Shape, size are also very important in these patients as you look at it. And I think as things evolve, there actually will be, I was being facetious, more machine learning that evolves that we can actually do simulations of these skulls and see if we're going to be able to be successful before we jump into real time. Next slide. In terms of technique in these patients with low SDRs, and we see a lot more of them that we had hoped for originally. I think one of the key things to start, and I give credit to Diane, who was sitting beside me out in the office from the beginning, who said, get the frame really, really low. Not only in front, but get the frame really low and back so you can really increase the number of elements. The number of elements that you're going to get on this are really important. Then then make sure that when you put the diaphragm on that you can really pull the folds down. The number of elements that you have that are shooting are going to be critical for your success. Next, in terms of sonication, the likelihood is you're not going to hit 57 or 58. What you want to really try to do is get over 50 for over 10 seconds, if you can. So instead of a quick burn, you're going to try to get for a much longer sort of cook on these cases, and you're going to lose efficacy very, very quickly. So unlike the cases where you have a lot of time to set up your alignments, to know where you're going, to be sure that there are no side effects, that there are no problems, in these low SDR cases, you're not quite as fortunate. If you don't go relatively quickly and go with some very high energy very quickly, you lose efficacy, and then you're just banging against something. You're going to go nowhere. So you don't have a lot of time, and you don't have a lot of sonications in front of you, which is unfortunate, but that's sort of the reality of these more challenging cases in terms of SDR. What do we have next? I think I don't want to take too much time. Yeah, here was a gentleman. This would be a classic example of a gentleman who came in with essential tremor, SDR 0.29. This is what it looks like, the sonication parameters. And then next slide, these are what the sonications, you max out relatively quickly in this patient as we did it. Next slide. And this is what it looks like in the end, your parameter. So yes, you can treat low SDR cases. You have to be judicious in how you treat them. There is a technique to them. I'll mention just briefly, I agree with Reese that high SDR cases are more dangerous for a completely different reason, and it has to do with the algorithms. It's actually the opposite of low SDR cases. Now you have to be very, very careful how you go incrementally in terms of your sonication, because you can actually overshoot. The algorithms often are not linear, and as you increase, you can jump and find yourself at 60 degrees or 61 Celsius very careful quickly before you knew it, and that's actually happened to us a couple of times. Thank you very much.
All right, we're going to move things along. Mike Caplet, you're next.
Can I have the clicker? It'll go faster. Thanks.
Oh, Jesus.
Thanks. No, that wasn't for you. I have more slides than everybody else, but they're all show and tell. So there are two issues that I just want to address here or raise for discussion. One, as Reese implied in his introduction, is how do you avoid recurrence? You know, for most of us, I think we have a very, good outcome from our original lesion. And I think most of us have the experience that about 90% of our patients have reasonable long-term stability. But this is a functional disease, and so we want to try to achieve 100% long-term stability. And how do we do that? So we published this years ago. This is a patient who obviously had a nice-looking thalamotomy, as you can see here, could barely put pen to paper, had a fantastic result. He was like 85 years old, former surgeon, went home an hour later. Everybody was thrilled, right? Comes back a couple months later with that recurrence there in the left, right? And we used tractography a lot. We saw a little bit of a recurrence, as you saw in the last slide, of the tractography. So obviously we thought we had a good lesion. It was a nice big lesion. The result was great. And if you think at the end that you have a great lesion and it looks good and patient's doing great, et cetera, and then you decide to do one more and now they have some dysarthria or ataxia, it's pretty frustrating. Why did you do that? On the other hand, if the patient comes back, you say, why didn't I do one more? So the problem is, from my perspective, is that we all struggle with this, I think, at the end. And many of us, I agree with Reese, many of us believe that we want to try to do the biggest lesion we can get away with, although not everybody believes that, but I think a lot of us do. But I'm not sure the size of the lesion is really the ultimate goal here. I think we need better measures of what the patient-specific lesion should be. Tractography may be it. I'm a big proponent of it, but I'm not sure on an individual basis that tractography is so reliable that that's the only arbiter. So I think we need a lot more science to better understand, because this is, this target is probably, the least definable target of everything we do in functional neurosurgery, anatomically, physiologically. Each case is very much trial and error to some degree, with a lot of, experiential knowledge base, as Gordon implied. So I think that's one area that's very important. And then the second question that was raised in the pre-meeting, discussion that I think is very worthwhile, as Reese said, right now, patients have to agree to tolerate only one side. And historically, I think we've always felt with essential tremor that if you can treat the dominant hand, who needs the other hand, right? But particularly in a therapy like this that patients perceive as less invasive, as more user-friendly, they go home the same day, they don't have a device to deal with, I think they have a lower threshold for wanting the other side done as a result, and we're starting to see how much the other side is important to them. So again, this is a patient, we did one side, you see the tractography, you see a nice lesion, they did well. And then as part of this multi-center study that Insightec had sponsored, that many of us participated in, we treated, this was 3 years later, they had to be at least 9 months out from their treatment. And again, you see the green dentatorubral-thalamic tract still there on the contralateral side. And so we treated that, and we did a nice lesion, and then those tracts are gone, right? So is it safe or isn't it? Because historically there was a lot of concern about bilateral lesioning with RF lesioning, and we are now working through a paper. The data has actually been submitted to the FDA already to try to get approval, The patients that had to enroll in this study or subjects were those that had mostly been treated commercially, so we didn't have a lot of baseline data before their original treatment. But obviously, we did have formal data before their second side treatment. And one of the things that I think is most striking is that while on the standard clinical ratings in Part A and Part B, they had the expected improvement in the contralateral arm, which was very analogous to what you see with the first side. Part C, which is the functional improvement, or the functional disability score, you see was roughly 75% improved over the course of the study, and our experience is that this is sustained. So I think that this tells you how important it is for us to try to get a handle on this contralateral side, because even though patients are much better when you treat their first side, they still have a level of disability with their other side tremoring that I think we have not addressed well enough because of the invasive nature of prior procedures, and which they are demanding more of now. And then the safety outcomes, which we are most concerned about, yes, some patients had some vocalization issues, et cetera. As you can see, some of them on formal testing had problems at baseline, even though subjectively they weren't reporting problems, which is how they were enrolled. But the number of new problems was clearly less than 10% in all of these cases, which is not too dissimilar from unilateral treatment and therefore is largely acceptable. So I think this is something we need to work through, and you know, we can talk about it as we move forward. Okay, here you go. That's for the next. Oh, sorry. How do you go back? Here you go.
Reggie, keep it rolling. We're getting the.
Will do. Thanks for the opportunity to join this group and to talk about our experiences. So we've touched on some of these points, and you mentioned patient-specific targeting and patient-specific outcomes. I'll make a pitch for some research that a colleague of mine, Dr. Bruch, is presenting here. And I think that one of the key points of the results that we've looked at, looking back at our patient population, is that actually we need a different metric for how we measure outcomes, and that the tremor score is not a good representation of how these people are doing. And when we talk about lesion size and lesion targeting, we actually need the patients to tell us how they're doing. On the left, you can see the day of CRST changes, going from blue to orange. On the bottom, you can see these grouped by patients that tell you whether they are better, the same, or worse. The CRST does not correlate, does not predict whether the patient is telling you they're better. If you look at those patients at follow-up, you can see, again, we're looking at how the patient tells you their tremor suppression is. You can see the group that is worse and the group that is better. They both are basically reporting nearly 100% improvement in their tremor suppression, but one group is telling you they're better, one group is telling you they're worse since the treatment. All right? So our metrics need to be different than what they are in order to actually help these patients improve. If you look, one of the things that we saw was lesion volume, and our colleagues here have talked about the importance of the lesion size. Part of what we've seen is that small lesions actually correlate very well with the outcomes in terms of quality of life, and in our cohort, it's about 140 cubic millimeters. You can see, as an example here, this is a patient on the top and on the bottom, A and B. They had the same CRST improvements. On the top, the quality of life is better. On the bottom, the quality of life was worse. The bottom one, you can see the lesion's a little bit bigger, and the overlap with our tractography target is a little bit worse. But again, CRST did not tell us this. The patient told us that he was not doing as well as he was before the treatment. What does this relate to? Well, so some of this is, again, as we've mentioned, location, size, shape. Obviously, the skulls are very different from each other. We've talked about that ad nauseum, how SDR and the surface area impacts things. There's more to it than that, as I'll get to. Obviously, targeting. We've all, as we've improved our targeting using tractography, we have a combination of an atlas-based as well as tractographic approaches that we use, and we have generated a hotspot approach using the combination of these approaches. We now not infrequently see patients that, as we're doing our initial alignment, are seeing significant improvement. So a very small volume of tissue is reaching a kind of a therapeutic, subtherapeutic temperature, and yet the patients are already showing improvement because the targeting is getting so good, I think. But beyond that, there is the shape of the spot itself and the tissue responses. So if you look on the left panel there, you see a graph that shows a variety of our patients, and that is energy versus temperature. And you can see that these curves are very, very different from each other. We all have patients that have SDRs, let's say 0.55 that behave like 0.4s, 0.45s that behave like 0.55s. The SDR is obviously a representation, but it is, as we all know, not the end-all, be-all. There's much more to it than that. That middle schematic shows you an example of this. This is the SDR map of 2 patients, and you can see in red are the areas of the skull that are more permissive and less permissive to the penetration of the ultrasound beam. The patient on the left, the vertex, is where most of the permissive parts of the skull are. The patient on the right there, it's coming in from the temporal bones. Those patients are going to respond differently in terms of how the spot is shaped and in terms of the contouring of that spot to the target area in the VIM. If you look, we are missing volumetric thermometry. These spots are oblique in every plane. Those thermometry images in the bottom right panel, on the top portion there, you're seeing in the sagittal plane that there's an anterior tail. In the bottom image there, the coronal image, you're seeing that there's a tail going out laterally and inferiorly. You can see what spot shaping does to this. On the bottom right image there, you see that there's a sonication where there's a significant smearing of the spot, both inferiorly as well as laterally. We then put on a mask, and you can see the subsequent sonication, how well it's contoured to the desired target area. So as an example, we have a patient like this that matches some of the examples that my colleagues also showed, where we targeted in the thalamus on the left side to treat his dominant hand, and you can see that there's an anterior tail, there's a lateral tail. This is a patient that went home and ended up with side effects. Facial droop, had some real issues. Thankfully, he improved over time. His tremor suppression was very good, but he did suffer side effects that required recovery. The same patient came back to us as part of our bilateral study, and with the improvement in not just targeting, but in our spot shaping skills, we were able to get the second side on the same patient without any of that tail occurring. So part of it is recognizing that you have this tail in all these different planes, that you are oblique in all these different planes, but part of it is knowing what you need to do in order to shape the spot as well.
I'll keep my part short, I think, so we can get to the discussion. But my name's Cheyenne. I'm at the University of Virginia. I work alongside Dr. Jeff Elias. My interest, as with the previous speakers, has been in optimizing outcomes for a patient, so that's maximizing the amount of time you have good tremor control, and also minimizing adverse events. So one of the benefits we have at the University of Virginia is we have patients that have been treated even up to a decade ago. So what I've done is actually looked at patient-reported tremor outcomes in terms of improvement. And what we can see, even going back as far as over 8 years for these patients, is that on average we have about a 63% improvement in patient-reported tremor. If you break that down into the median follow-up time, which was about 3 years, you can see that there is a decline in patient-reported tremor control, at least that we saw from this survey study that we did. Regardless, 90% of patients, regardless of their follow-up time, were satisfied with the procedure, which is indicated by their willingness to undergo the procedure again. So, going along with the previous speakers, what can we look at to determine and predict what the durability of the lesion will be, the extent of tremor control, and also be able to predict their side effects as well. From what we've seen so far, obviously the size of the lesion matters, particularly for side effects. We saw that the T2 lesion volume is very predictive of the amount of imbalance that patients will have. We've done the same for tremor-dominant Parkinson's disease as well. The follow-up time is less for these patients. At maximum, we had 3 to 4 years of follow-up time. But if you break them down into the duration of follow-up with a mean follow-up time of 16 months, we can see that there is sustained tremor improvement for these patients. So, going along with the previous speakers, being able to predict how the outcomes will be is going to be extremely important. And as we get more and more data, more and more imaging for these procedures, we can potentially even use deep learning algorithms to predict that as well.
So I wanted to thank being involved in this. I think neurologists aren't necessarily involved in this protocol as much as they should be, and that's part of what I'm going to talk about. So I don't have a lot of data on why neurologists get involved and why they refer patients to this. When we were talking in the pre-discussion, one of the questions that came up is why patients ask their neurosurgeons why they had to find out about this on their own and why they weren't referred for these procedures. So with no data, one of the things I did was went and talked to neurologists, and I asked them why they weren't referring people to focused ultrasound. Some people just don't know what it is. They referred back to lesional work and said, isn't this going backwards? People were pushing to go from DBS, from lesional work. Why are we going backwards? Why would I refer for focused ultrasound when the patient should have DBS? And I had a lot of questions about the 2016 paper and the amount of side effects, and I was basically told that aren't 40% of patients having strokes when they have this procedure done. And then I went to our data and talked to why patients were asking for this procedure. Often they're relating it to DBS as well. They report that they're technically challenged and they're afraid of the DBS and having to use a remote themselves. Some people have complications with previous DBS infections. They don't want a device implanted in their brain. They couldn't get DBS for one reason or another, medically, physically. Or they don't have good support at home, or also that they are afraid of the medical community. And then one patient reported that they had a family member that didn't have an effective DBS. And so to me, this brings up a few observations and things I think we need to talk about in the future. One is that general neurologists are usually or unaware of the procedure, and movement disorder neurologists who are more aware tend to be a little bit more skeptical, often because the papers they are reading aren't the most up-to-date, or they're not reading the right journals. And so I'd suggest to neurosurgeons and neuroradiologists that are involved in this process that neurologists should be more involved from the beginning, and this should be a discussion that's going on in your areas. Also, I just briefly went through the publications of tremor-dominant focused ultrasound, and the vast majority of publications right now are still in neurosurgical journals, and I'd suggest trying to get some of this stuff into journals that are a little bit more applicable and more neurologists are reading. We need to get more neurologists involved at the resident and fellow level, which I think even at our institutions, there isn't that much involvement. I also want to put a plug in for me, who's involved often at Maryland. I was going into the ultrasound suite, having a neurologist involved in the procedure itself and making decisions, because what we do every day is look at tremor, and we're good at evaluating for functional effect of tremor, and not having us in the room can help make these decisions that we're talking about. I think we're often presenting focused ultrasound as an alternative to DBS. You get DBS or focused ultrasound, and often I don't think the patients that could get DBS that can get focused ultrasound can get DBS. And I'd suggest proposing that we think about, instead of DBS meetings, we think about interventional meetings and presenting all difficult neurological or tremor patients to these panels so that we have multiple modalities that we can talk about and discuss what's appropriate for a patient. And then while I don't have a lot of data on this, this is something I'm personally interested in movement disorders in general, the typical patient tends to be white, male, high medical literacy, and middle to high socioeconomic status. And I think focused ultrasound, particularly because of the type of technology it is, can be a real way for us to get some of these advanced therapies to populations that would otherwise be underserved and not getting some of these treatments that could really make a difference in their life. So that's all.
Sorry, I'm Vibhor Krishna. I'm at University of North Carolina, Chapel Hill. I don't have any slides. But the observation that I make from sitting in this panel is that essential tremor is the most advanced indication that we have for focused ultrasound in the clinical realm. And in the next phase, we have to optimize this procedure. And so this is a shout out to all the young, bright minds in the audience who are listening to this, is that all the clinicians on the panel want to have outcomes that are reliable. We have heterogeneous outcomes. We have outcomes where patients have side effects. We have outcomes where tremor comes back after a certain time, maybe a month or sometimes even delayed. And so I really liked what Paige's point was, to have a personalized way where you identify the target at individual patient level and maximize the ablated tissue to that target, where you keep the ablated tissue within the boundaries of the target and avoid any side effects from adjacent area ablation. And so the idea becomes to maximize your accuracy, keep within the boundaries of the target, and ablate majority of the volume of your target. And so that goal would require for us to have advances in tractography that would convince all these experienced surgeons and radiologists to adopt it for individual patient level treatments. It would require advances in beam shaping, as Paige had mentioned, where we don't have smearing, and that we could have a very reliable and predictable heat map. We would need ways to monitor the lesions more accurately. Thermography can help us to look at increase in temperature, but inherently it has limitations in terms of shifts. And so the location of your ablation is not accurate. And so we need ways where we could have very accurate delineation of your lesions and superimposition of that on your preoperative imaging. And that's all I will say.
So we do have some time for questions. You can either come up, if you're here live, you can come up to a microphone, or you can submit them on the virtual platform. One of my burning questions for the panel is, what do you do about your failures? Do you do anything if you're going to retreat somebody, how do you approach that? And I guess the other question that came from the audience was, if you've had trouble obtaining a lesion, does gamma knife radiosurgery have a role in treating patients with relapse, recurrence of tremor? Cheyenne.
I think at UVA we've had a handful of retreatments that we've done. If the patient has a reasonable SDR, then we can elect to retreat again using the same techniques. Although if we saw that there was a small lesion on the postoperative MRI, then we would aim for a larger lesion the second time.
Do you target any differently?
It depends on what we see on the post-op day 1 MRI scan or follow-up scans. If we see it was more medial than we expected, then we may push it more lateral. If they have ventriculomegaly, then we may see, okay, it does need to be more lateral. We don't use tractography much, although that's something that we'll be using more in the future. And I agree with Dr. Krishna that certainly would help us with the targeting. And then also, if the problem was due to a low SDR or difficulty with heating, then we would elect potentially for DBS, and we have published that that's an option after focused ultrasound lesioning.
Okay. Mike?
Yeah, the one thing I would add is that for us, even though we've had a small number of retreatments, no matter what technology we use, looking at where the lesion is relative to landmarks, looking at tractography, et cetera, in the end, I'm not sure with our very small experience that anything correlates with anything, right? That we're absolutely sure of what the issue is. But the advantage of ultrasound, I think, compared to invasive surgery, as we talked about last night, is the way we approach it is we go to where we think we should go, and if we don't get good tremor control, we can go kind of around the lesion and find the area. And as long as we're not hurting the patient, it's a lot safer and easier to try to sort of do little lesions around the existing area until you find where you think it is, than with invasive surgery when you have to do a recurrence, you've got scarring and you've got to poke the brain, all these things that I think are much riskier. So while we're all worked up about recurrences because we don't want them, I think this is a technology that's actually well suited to trying to retreat patients, as long as it's not too often.
Peggy or Vibor or Gordon, do you have comments about your strategy when you're doing a redo?
Yeah, I think it depends, as like Michael Jordan say, you succeed through your failures, So let's say your worst failure is like you get bad side effect, which is permanent, and you don't get tremor relief. Now, I'm a little concerned about jumping back in and doing ablation after that. So I'll rescue with I'll offer a DBS as a rescue because it's neuromodulatory, and I'm a little more comfortable. If the patient's already had a deficit, I don't want to add insult to injury with more of a deficit. So that would be one type of failure. Failure was mentioned before. You have a low SDR case, and you fail that way, and you think that you did your best. That may be a rescue, either with Gamma Knife or DBS. Give the patient the option. Let's say a failure where you didn't get enough elements on. Frame wasn't low enough, and you figure you could have gotten the frame lower and done a better therapy. You might want to retreat, then get more elements on and see if you could get better heat. And then there are the ones that have been mentioned by Mike and others, where you do tractography and you missed a little bit, patient's okay, and then you may want to retreat with better tractography. And I think, as he said, it's an ideal patient, an ideal system for retreatment, and the system is really, really well set up to do that type of stuff.
I'm going to take a question from the audience.
Perfect, thank you. I really want to thank all of you. That's been a fantastic panel, and as a commercial user, not currently involved in research, really everything we do is predicated on the work done by you folks and a lot of the other folks out there. I'm going to be doing my 290th through 293rd thalamotomies on Monday, and still, every time I go in there, the question that keeps me up at night is, how do I know when I'm done? and I would really just love to know sort of your different approaches to that thought, because at the end of the day, that's what's keeping me up at night.
That is a great question.
Yeah,
When are you done? Is it, or do you have to do more?
So I'll tackle that one first. And so we used to rely very heavily on tremor and look at tremor reduction. An interesting thing is what Reese has observed and commented on earlier was that we don't leave the operating room if there is even a little bit of tremor. So everyone tries to get to the point of 90% or more tremor reduction. And what we realized is that when you start to do ablations, intraoperative tremor reduction becomes unreliable. And it makes sense because you have ablated a small tissue, and then there's a ring around it that has partial ablation, and there's a much bigger rim around it that has thermal neuromodulation. And so all of that tissue is in play, and what you're seeing intraoperatively is tremor reduction, which is remarkable. And so we took an approach in this which is completely from a imaging guidance standpoint or imaging-based approach. And so we have the VIM ROI, and the goal is to just ablate maximum volume of that VIM ROI. And so if I have with one ablative sonication only 30%, I'll go with another one. And the goal in my mind is to get 70% or more. And what that ends up in doing is that you create big lesions, and that's why imaging guidance with tractography allows you to create safety margins so that you don't have side effects. And so that's the approach we have taken.
Yeah, we get tremor control basically in everybody on the table early on, sometimes with just the alignment sonications, and then what do? It's a volume thing. It's a location and a volume thing, and even when I've got good tremor control, I'll sometimes do a final, what I call a cementing lesion, just on the same target that I got my initial tremor control with, just to avoid recurrence. But I don't know if that's true or not. Does everybody on the panel trust the Insightec isothermal maps as in terms of their accuracy in spatially and volumetrically? I have come to trust them pretty well because I correlate them with my post-op MRI scan. So I give Insightec. I didn't at first. I sort of do now, but it's still the same question. So it's a combination of that. That's where the judgment, that's where the art of focused ultrasound thalamotomy comes in.
Yeah, I would say you've done, you're a very seasoned neurosurgeon. I would also, this is not scientific, listen to your inner voice. There's an inner voice that talks to all of us that says stop. When your inner voice says it's time to stop, it's time to stop. And listen to that voice. The other thing, and Reese can comment, Dr. Bertrand taught me when we used to do the thalamotomies some years ago, is when the patient gets a little numbness or feels a little numbness right there, that's when it's time to stop the day. Yeah.
You also have to take individual patient characteristics into account. If you're treating a 90-year-old patient who already has baseline imbalance, you'll want to, I'm usually much more conservative in that sense as well.
I have a question for the panel. Are there patients that come in wanting focused ultrasound that you say no? Peggy and maybe Margaret, you've had a lot of experience seeing them afterwards. We exclude the really elderly patients who already have horrible balance and using a walker and are tentative and live alone.
Yeah,
Then that's not going to do it.
Yeah, so I would say that for me, in evaluating someone for referral, that the things that would make me concerned, age is not really an issue by itself, but age combined with other factors, sort of overall general health, we're more permissive than with something like DBS, but you still want to sort of evaluate. I think I would not do it on someone who is older and who had a milder tremor, that it wasn't as impactful on their daily functioning. I think balance is very important, how well they walk beforehand. And also baseline dysarthria can contribute because I think you are less able to detect some of the capsular effects that you can see during the procedure itself. And those would at least make me much more conservative in the way that I approach the procedure, if not prevent me from actually referring.
Do any of the panelists think that they're better at relieving one sort of, in essential tremor, there's postural tremor and there's intentional tremor. In my experience, it's harder to get rid of the intentional tremor, and some of my redos are because they've tasted perfection, they could write and do everything again, and the intentional tremor comes back, and I've had mixed results on retreating those.
So I would just put a plug in that sometimes that's one of the reasons why it's useful to have a neurologist around, because...
Really?
But I think that one thing that you can see is that with some of the treatments, you can actually end up with a mild dysmetria, which can look like an intention tremor and is not an intention tremor. And that's one of the side effects that can actually come up from this. I'd also say one of the things we saw at Maryland a lot that we had trouble getting rid of and we actually stopped pushing for is that people can have sort of a large, almost twitching. You can see the tremor wanting to emerge, and that is very difficult to get rid of, but actually has very little functional impact at the end. And the patient's like, oh, I still have a little bit of tremor, that they can do everything with it.
Libor.
Yeah, well, one thing I would say is that we tend to pretend that all essential tremors are created equal. They're not. I think it's a mixture of different kind of disease processes that share a common phenotype of tremor. And I've seen that, at least in my experience, that patients with essential tremor who have neuropathy have worse outcomes, and that was the DBS experience as well. There are tremors where you have a delayed onset in ADs, and it's a rapidly advancing tremor. Patients tend to have worse outcomes. And then the point is well taken. Sometimes with tremor treatment, you unmask ataxia, and then all of a sudden the patients have worse outcomes. And so shout out to, again, more research needs to be done to have, this disease entity researched more to figure out, what are their different clinical syndromes within this phenotype of tremor.
Well, as you can tell, this could go on all day. But I thank all of the panelists for sharing their experience. This is functional neurosurgery. This is a wonderful tool. We still need to know how to use a tool. As Lexel said, a fool with a tool is still a fool. These are no fools up here, but our goal over the next few years is to perfect the art of focused ultrasound thalamotomy, and we're on the verge of doing so. So with that, I will end this panel discussion and turn it over.
Really, thank you all for sharing your expertise, and I think you shared your experiences, your knowledge, and also are making us critically think on how we can do everything better. So I have a lot of notes of things that we need to support research and help really improve these treatments. So thank you again. So now we're going to take a break. It's going to be a little shorter because we ran a little bit late. We're going to get back here at 10:18. We want you to remember to visit our exhibit booths on site or the virtual exhibit halls. For the virtual platforms, please click on the link at the bottom of the page to access the next session, or click on the Parkinson's Disease Movement tab to get back in. I hope you enjoy the break. Today's breaks are sponsored by Insight Tech, so please enjoy the food and drinks outside, and we'll see you back here at 10:18.